Hi there everyone, welcome to the second part of our clinical radiology applications overview. My name is Mohammed, I'm one of the RadCast co-founders. If you haven't already, make sure to start with part one, obviously but in part one what we do is we cover an overview of the application as a whole in the sense of the major changes, things that were the same, competition ratios, and in this one what we will be covering is the multi-specialty recruitment assessment. So let's get started. Now, the multi-specialty recruitment assessment is everybody's best friend. It's the thing you look most forward to when you wake up, and it's the thing you think of before you go to bed. Obviously, I'm exaggerating very poorly, but exaggerating nonetheless. It's the thing that really makes everybody hate the application process. It's the thing that everyone dreads, it's the thing that everyone hates revising for, and it's the thing that makes candidates really anxious and apprehensive when applying. It's not changed since it was introduced back in 2016, and it hasn't changed in the last year, and we don't think it will change. All right, it's the thing that is often the bottleneck for a lot of candidates. It gets them off guard. They're not successful in the shortlisting process, all because of the MSRA. So it's very important you take this exam seriously. Yes, you may not like it, but at the end of the day, it's part of the radiology application process for now. So just get on with it. In terms of an overview, we do not claim to be experts in the MSRA. There are other providers out there which cover the MSRA in a lot more detail. I will name a few that we recommend, but this is just an overview sort of what to expect, all right? So it's a computer-based exam, initially introduced for the general practice recruitment, but now it's used by a lot of specialties, ophthalmology, neurosurgery. In the 2022-2023 cycle, core surgical training started to utilize it, and of course, radiology has been using it since 2016. You will often do the exam in a Pearson VUE center. They are internationally available centers as well if you want to sit it abroad. But for those of you sitting in the UK and have done the driving theory test in the UK, it's the same centers as those, okay? In terms of the structure, it was similar to previous years. There's a professional dilemma section and there's a clinical problem solving section. They have different amount of questions in terms of volume. There's no negative marking, and there are pilot questions, but you're not told which ones are which. So of course you have to give every question your best effort. Now, when it comes to the MSRA, as doctors, typically when you're applying to radiology, most candidates are not coming from foundation program, FY2. You often gravitate towards the clinical problem solving. It's just like a duck to water. You're doctors, so the clinical problem solving is a thing that is a lot more comfortable to prepare for and to answer for, because you can often utilize past experience to help you gauge what the correct answer may be. The difficult part of this application when it comes to the MSRA is the professional dilemmas. This is the one where you're having to often do mental acrobatics and gymnastics, all right, at an Olympic level to get that gold medal, because you have to often realize that there are no set guidelines when it comes to ethics that has very clear protocol. For example, principles of consent, scenarios where you can breach confidentiality. Those are often questions that aren't asked in the exam because it's so clear cut. All right, you do X, Y, and Z in that order. So often in the exam, unfortunately, you'll get these very ambiguous ethical scenarios where you're just scratching your head thinking, what do I think the examiners want me to do? And what order will that be in? That's literally the type of thoughts you're having. It's not like, oh, I remember in the GMC guidelines it says X, therefore I will put number one in the third position. It's not like that. So often candidates really struggle with the professional dilemmas, and often it's because of this entire section that candidates hate the MSRA overall. All right, if it was just the clinical problem solving, I don't think MSRA would get the hate that it does, but it's because of the ethical questions as well that it gets a lot of bad press. All right, but once again, it's the game you're playing. It's part of the application process. You just need to figure out a strategy to help you maximize your MSRA score. In terms of the MSRA from our perspective when it comes to application support, please do not take this exam as a joke. It can and it has really messed up people's applications. We have had to support candidates where this is their second attempt trying to get into radiology, and it's always been the MSRA, all right? Because like I said in part one, the MSRA is not only used to determine if you are shortlisted for an interview, but also it's your final rank. So we know candidates that we've supported that have like amazing portfolios, like on the verge of full marks or full marks. And the MSRA just keeps screwing them over. They can't get through to interview. And we know they would do well at interview, but the MSRA is that bottleneck. And like I said, it's annoying that it's this. And candidates have mentioned their frustrations, but it is the game you play. So you've got to take it this seriously. Yes, you may be a medical registrar in hematology. Yes, you may be the orthopedic ST4. But at the end of the day, you will realize when you look at the blueprint for the MSRA that there will be things you haven't covered since medical school finals. I'm giving examples such as pediatric rashes, immunization schedules, the asthma pathway, all right? You may not have covered those for a long time, especially if you're more in a like senior specialist role in another specialty. And you got to go back to your books. And the difference between you now applying as a doctor compared to medical student time is you now have other additional responsibilities. You now have clinical demands on calls, night shifts, weekend shifts. Secondly, you will be having to prepare your portfolio for your existing training program and for like getting ready for the radiology application. Thirdly, you've got to do portfolio stuff. All of this is eating at your time. It's not like medical school finals where you DOSed for 10 months of the year and in the last 2 months you crammed and then nailed the exam, all right? Similarly, you may now have family which you don't have back in medical school days. That takes time out of your day as well. So you've got to give the MSRA the respect it deserves. And give it the time that it deserves. In terms of cutoff scores, you can see on your screen that it is creeping up. 2 years ago, it was 521. Last year, in the 2022-2023 cycle, it was 543. We think it's going to jump up again, 560. Now, that isn't us at RadCast doing next level mathematics where we go, oh, what's the difference between 543 and 521? We have put a bit of thought into this in the sense that we're now looking at the pool of candidates applying that to a specialty program that requires the MSRA with the influx of core surgical training that has added to that pool. So we think it will creep up further as candidates who are not potentially just applying for radiology but may consider adding in a radiology application also are using the MSRA for other specialties. And remember, any marks that you lose in the portfolio and in the interview can be made up with the MSRA. And you got to remember finally that the multiplier used to convert your raw MSRA mark into a scaled MSRA mark can fluctuate depending upon the performance of the candidates. So whilst the conversion for portfolio and interview raw marks to a scale marks is often very simple, it's often like a factor of 2. For the MSRA, it can change depending upon how well the other candidates did. So once again, if you're going to put time into anything, you should be looking at the MSRA as top of the list. Then for now, depending upon the time of the application, I'm recording this in May, you should be looking at portfolio. Of course, if you're now shortlisted for interview, it's going to be interview. You've done the MSRA by now. But for now, MSRA should be getting its due diligence in the sense of you reviewing the content, revising topics you may really struggle with. For example, hematology is a big one, all the different anemias, and giving it really a good go in terms of your revision. When it comes to revision resources, there is a lot out there. And this is the stuff we would recommend that you make sure you've had a look at as a minimum. So, of course, the Bible equivalent of any ethical principles is the General Medical Council's Good Medical Practice. Yes, it's not the most riveting read. It's not going to be on the level of Harry Potter or Lord of the Rings or maybe 50 Shades of Grey if you're into that. But it's something you need to read because it tells you exactly what the GMC expects of doctors. So as a baseline foundation for you approaching questions in the ethics, you can be like, okay, I know GMC recommend this, so this would be ranked higher than that. It gives a good foundation. Similarly, the GMC have taken it a step further and made these like dynamic scenarios, interactive scenarios, where they take a core ethical principle, for example, confidentiality, consent, end of life, and give it into an interactive scenario that you can play through, where it looks at what the outcome would be if you choose different like options. It's a much more engaging way of learning ethics, which can often be, from books especially, quite a dry topic. Now, when it comes to books, you need to go back and get your Oxford handbooks out, all right? They're probably gathering dust if you haven't used them since medical school, but those are the bread and butter in terms of they will be up to date in terms of guidelines, in terms of like the whole disease pathway, incidents, epidemiology, risk factors, signs and symptoms, investigations, blah, blah, blah. So go back to your Oxford handbooks, print out the MSRA blueprint in terms of the curriculum, and look at which you think your weakest subjects are, and then reread accordingly. The book in the middle, the Situational Judgment Test, is probably one of the better books out there for the ethical side of things because it's the more up-to-date version of the books. Often a lot of the MSRA ethics books are quite outdated, and this one of the key features of it, the key pros, is that when it talks about like ethical principles, it will reference like either GMC or existing like laws or regulations. So you have a framework and an anchor point for any other question that may talk about the same principle in terms of ethics, but uses a different clinical context. And of course, that's what they're going to do in the exam. They're not going to regurgitate the same question word for word. They'll have the same theme, but different wording of the question. When it comes to question banks, there is a lot out there, and we're not going to deny that. But the ones that we recommend are MCQ Bank and Past Medicine. Now, please, we are not being paid by them. This is just based upon our own experiences, having sat the MSRA, but also from prior candidates who've smashed the exam. In terms of what you start with, we would recommend Past Medicine because in terms of the clinical side of things, they are very guideline driven, and that's exactly what you want from the clinical problem solving. You want to, for example, deal with a hypertension question, and then bam, the explanation tells you exactly the nice hypertension pathway management. All right. Same for asthma, same for any clinical scenario. Because like I said, they may take hypertension as a theme, but change the stem. So you would have to pick a different medication. When it comes to the MCQ bank, similarly, it's very good for the breadth of questions you can be exposed to. And we have been informed from prior candidates that some of the questions that they've encountered have then come up in the real MSRA. That's from candidates. Whether that's true or not, I will leave it up to you guys who then have to sit the MSRA, but that's what we've heard. Similarly, we have spoken to very top achieving MSRA candidates. The most recent one was with Craig, who's now going to be finishing his ST 1 year. He was applying 2 years ago. Apologies for my horrendous hair in the thumbnail for this video. It's better today, but I was probably clearly just woken up or something. But Craig nailed the MSRA. He got like 600 above, I think. And we've spoken to him about his strategy, about what he would recommend, and his approach to the MSRA. So if you've got a spare 49 minutes, which for a critical part of your radiology application, you don't have to put it on 1x, you can put it on 1.5x. You can go full Ali Abdal mode and be productive through increased speed of your videos. You can watch it, go through it and take away the tips, all right? Learn from those that have achieved what you want to achieve, all right? It's a time-tested strategy, all right? Craig has done the hard work, he's got the experience, and now he can like instill that into you. So make your revision effective and productive and very high yield when it comes to making use of your time. Once again, this is going to be a recurring thing I will say in every part of this series. You need to prepare now. MSRA is a thing that everybody thinks they have more time than they do. Before you know it, it'll be November. You'll be submitting that application. And then bam, you're in a Pearson VUE Center getting asked to rank some ethical scenarios based upon what you do if you hit your toe in the door and something ridiculous happens, right? It will creep up faster than you think. Right now, when I'm recording this in May, candidates like to focus on the portfolio because it's nice to collect certificates. It feels nice to get that email from the consultant saying, here's your taster week letter. I don't know, it's a very primitive amygdala thing, I think. Well, I'm not sure. But the elephant in the room is the MSRA screaming, but you're giving it falling on deaf ears, all right? Those screams will get louder, and before you know it, you'll be like, oh my God, I have forgotten everything about COPD management because I've not done it for X amount of years. Especially if you're in F2 where you're just doing TTOs and cannulas and venipuncture and I don't know what else ward work related. It's not clinical medicine per se. And because of the nature of medicine, things could have changed since you sat it in medical school finals. So you need to make sure you're practicing up-to-date medicine when it comes to your clinical problem solving. And similarly, the ethical, you need to give it a good chunk of time to get familiar with the ethical principles. So please start preparing for it now because the MSRA is your bottleneck to interview. Doesn't matter if you get 100% of your portfolio, but don't get the cutoff for MSRA. Nobody's going to see it. It will not reach the light of day, and that's a shame. Okay, that's a big, big shame. We've had candidates every year fall into this trap, and seriously, I can't give justice to how upset they are and how disappointed they are and how distraught they are. All right, so we don't want that for you guys. So please take it seriously. And once again, our doors are always open for you. Please just email us at hello@radcast.co.uk and we'll email back, see what part of the application you're at, what support you need, and give you personalized advice into how to maximize your application going forward. So that's part 2. In part 3, we'll be covering the interview, and in part 4, we'll be covering the portfolio and what changes there were and how you can maximize your portfolio for this year's application. Take care.